Hi, and welcome to the TRT and Hormone Optimization YouTube channel. All right, so hi Gil.
Hello, how are you?
I'm fine, thanks.
Good.
I have an echo here. Let me try that out. So many windows open. So how are you, Gil?
I'm not bad. Yourself?
Fine, fine. Busy days.
Yes, sir, indeed.
Next to the work, the family, the YouTube channel, also doing politics because we have elections coming on.
I saw that you're running for public office.
Yeah, it's the local election for the
Yeah,
town.
yeah. Good luck.
So this is the SVD badge. It's Samen voor Democratie, Together for Democracy.
Okay.
So we're very opposed to government control.
Very good. So it's also I don't know about the V, but the SD are your initials too.
It is. It's what my wife said. It's like Steven Devos, but
Yeah.
it's Samen voor Democratie, Together for Democracy.
Okay.
The V is for. Yeah, whatever. I'm still looking for that window that is giving my echo. It's not this one. So keep on the questions coming on in the chat box, guys. Here it is. Okay. So Gil, let's start with this video request we had from one of our viewers. God, I still have an echo somewhere. All these windows. Do you hear this echo, Gil?
Very slight. Yeah, there's a little bit of a slight echo delay on your mic. Is my audio okay?
Your audio is fine.
Okay.
Well, I'll just pose the question so you can get on with it. So we had a video request. Gil, a comprehensive video on sleep issues with TRT. All that's out there now is just video clips with truncated information. I've been on TRT for about 20 weeks now and still haven't figured this part out. When my dosage is where I feel good, I can't sleep or for shit.
Okay. So much like other symptoms that men often associate with low T or assume that testosterone replacement is going to fix, sleep is a big one. Sleep is usually the one that is responsible for a lot of symptoms that we find detrimental to our life, or I should say poor sleep or lack of sleep. And oftentimes men feel, well, if I can go on testosterone, a lot of these symptoms will go away. The problem is that it's not always, and more often than not, it is not your low testosterone that is ruining your sleep. It may be the lifestyle that you are leading as a result of the low testosterone, lack of exercise, lack of focus, lack of motivation, which leads you to not line up a schedule throughout your day, lack of caring about what's going on, letting your health go. Those are things that are directly related to having low levels of testosterone for elongated periods of time. The problem is that when you get on T and you expect within a couple of weeks for all of that to go away, you have to understand that you now have to do a lot of work to undo some of the damage, whether it be weight loss, whether it be starting an exercise program, whether it be changing your diet, whether it be eliminating various environmental stressors on a daily basis. Sleep is a very multifactorial aspect, and it is not a magic pill. It's not like you start testosterone and a week later you sleep like you did 20 years ago. The biggest tips I can give you in a short period of time to improve the quality of your sleep is, first and foremost, stop using electronics in bed right before you go to sleep. People bring their phones, their laptops, their iPads, and their televisions into their bedroom, and they usually fall asleep while using these devices. The light and the stimulant from the device and the information you're processing is going to prevent or inhibit your pineal gland from releasing melatonin. We need darkness or a level of calm levels of light, not a big light in our face. We need to not be processing politics and drama and world issues right before we're ready to fall asleep. You need relaxation. So eliminating those stimulants from your bedroom right before bed is going to be the best thing you can do initially, because that you could do immediately starting tonight. Changing your diet. Don't eat right before bed. If you're going to dinner at 8 p.m., coming home at 11:30 and flopping over, again, you're going to have a hard time sleeping. The heartburn, the indigestion, the burping, the processing of the food through your gastric system is not going to allow you to have a peaceful night's sleep. So I recommend at least 2 to 4 hours prior to actually getting into bed. Don't put anything in your mouth. If you want to sip some water, that's fine, but let your body kind of relax from that point forward. Don't go to sleep on a full stomach. If you're on the heavier side, and we see this in my clinic all the time, we do intakes and we tell guys they're a little heavy, and they say, "Oh, I'm not heavy. I'm perfect for I'm 5'8", 210." No, that is heavy. You need to, I hate to sound primitive, you need to go back to the BMI scale. I don't care if you're muscular or if you are, fatter from adipose tissue. Your body has to pump blood, and your body also has weight, pressure on your chest. If you sleep on your back and you have a larger chest, you can be 5% body fat with abs and a solid bodybuilder. You have weight and pressure on your diaphragm. Your body's going to struggle to breathe in an autonomous state when you're laying supine on your back. So you need to reduce the amount of mass if you really want good sleep. Bodybuilders have sleep apnea. Bodybuilders use CPAPs. If your neck is larger than, I like to use 17, 18 inches, the board's question, actually, I saw one come up that said, sleep apnea is higher risk in patients with X neck size. It was 16. So if your neck is above 16, according to medical literature, you have a higher risk of sleep apnea. You may not wake up or remember that you woke up, but you're not going to be in REM sleep. So you're going to be exhausted the next day. These are just little things you can do. In terms of supplements, I love ZMA, zinc, magnesium, and aspartate. It's a 3-in-1. It really helps to relax, helps you to sleep before bed. I recommend 3 capsules for men, 2 for women every night before you go to bed. If you need a little melatonin, whether it be in tab form or sublingual, nothing wrong with that. There's a lot of things you could do to improve your sleep. Thinking that taking testosterone will do that for you is just a flawed thinking process. And, in the long term, testosterone is going to give you the ability and motivation to perhaps make the changes, such as exercise, weight loss, etc. But in and of itself, it's not going to improve your sleep a whole lot.
Yeah, sure. Yeah. I'm about to come off TRT cream after almost 2 years. I figure I will do 2 weeks HCG, 2 weeks tamoxifen and HCG, 2 weeks just tamoxifen. Any dosage tips, expected time range before my test returns?
So you're coming off testosterone cream and you're trying to kickstart your endocrine system utilizing an LH analog, which is HCG, and then a selective estrogen receptor modulator, which is tamoxifen. No one can answer the question for you because we don't know what your initial diagnosis was. If your initial diagnosis was primary hypogonadism or testicular hypofunction, then coming off TRT is never going to replace your natural production sufficiently because
Oh, Gil is gone. Give him a few minutes. He's back. I'll let him back in.
I don't know what
You're
happened.
back. You're back.
Sorry. Somehow it just said camera off. Anyway,
Okay.
could you hear my audio when it disconnected or not? No. Okay. So basically, if your testicular function was diminished over the course of your lifespan, whether it's due to acute injury or it could have been a slow decline over the course of time. Either way, if your testicular function has diminished, then trying to come off and letting your body naturally replace it is a moot point. It's just never going to happen. If your issue was secondary, which is a pituitary or hypothalamic problem, then restarting that loop may, and I say may with an asterisk because oftentimes it fails, but it may work for you. My question is, why do you want to come off? And why do you want to, go back to a state where presumably you were previously deprived of optimal levels? Now, my guys shouldn't come off because my guys are started on therapy because they are deficient. We don't start guys who are just curious and want a little pump for the gym. We start guys who have a medical necessity. So if you started for the right reasons, you should not be coming off testosterone. If you started for the wrong reasons, then again, we don't have your initial assessment to be able to diagnose and or put together a plan of action as to dosing and frequency. I don't know your age. I don't know your medical history. What we can do is we can give a blanket statement that is based on scientific evidence. What we cannot do in these video sessions is give specific medical advice to individuals based on their needs, because that does require a proper assessment. And anyone that's going to come on here and just say, here is your dose, here's your frequency, here's what you should be doing, outside of being highly illegal, it is unethical and it is just morally wrong to advise someone you know nothing about.
Gil, while you were gone, my echo was gone as well. Dave Perez said. So this echo I hear all the time comes from your end. When you were gone, my echo was gone.
Okay.
Do you have another screen open?
No, this is the only microphone I have going. Let's see.
You don't have another screen? That's repeating myself? Because I hear myself back.
You know what? Maybe let me lower my volume on the speaker. Maybe the speaker's coming back into the microphone. How about now? Is that better?
Stephen, you are still in an echo chamber. Is it better now, guys? Let us know in the chat. Is the echo better? Yeah. For me, it is. I don't get myself on the echo, so must be better.
Is this
Someone
better
wrote,
now?
yeah, it's all right. It's getting back now.
You know what happened? I purchased a new microphone, and I think I may have had it flipped where it was picking up the speaker side instead of my side.
Okay. Big echo on the European. That must be me.
I'm European 3 generations ago.
Okay, let's get back to the first question I skipped. Good morning, Doc and Gil. My latest refill doesn't seem right. The rubber stopper was harder to pierce in order to draw up. Once I did, I noticed that the oil was much thicker and rancid. Is this normal?
I don't have enough information. I don't know what syringes he's using, and I don't know what carrier oil he's using. I don't know what pharmacy it came from. I mean, is it normal? Depends. I mean, if he's using a thicker oil, if he's using sesame seed oil and he's using the wrong size syringe, then it is normal. If he's using the right size syringe and needle and he's using a thinner based oil, then he shouldn't have a problem. It's hard to answer a question without the facts.
Good morning from Texas. Well, good afternoon from Belgium here. Any other tips regarding coming off my TRT cream? The other guy added, Choco. Can you give him any advice when he wants to come off?
Again, we need to understand why you got on in the first place. We don't know your medical history. I don't know if you have testicular hyperfunction, pituitary hyperfunction, hypothalamic hyperfunction. I don't know your age. I don't know how long you've been on. I don't know why you got on, and I don't know why you're coming off. And I don't know if you have any comorbidities, or if you're obese, or if you're on any other medication that may cause a rise in SHBG or a hindrance to your endocrine system. Without all of this data, I cannot give you specific instructions as to what you should do next, unless I have the history of where you came from. And I'm not saying this so you can go out and type along medical history. We're not here to assess individuals. This is, again, blanket policy information based on evidence and science. We're not here to diagnose specific individuals. So my whole thing about coming off, your provider should assess why you're coming off, why you were placed on, and what was your initial diagnosis. Low testosterone is not a diagnosis. Low testosterone is a sign. It is something that is seen on labs. Symptoms of low testosterone are just that. They are symptoms. The diagnosis is what failed in your body to cause the signs and symptoms that we are presented with. And if you don't have a diagnosis, then someone treated you without diagnosing you, that is irresponsible.
A very general question there. Which hormones affect erection quality besides testosterone?
Which hormones affect erection quality besides testosterone? Okay. Prolactin is a big one. A deficiency of estradiol is a big one, often caused by 2 primary causes. One, aromatase inhibitors, or the disruption of aromatization via other forms. Or 2, a low state of testosterone in a male, which then leads to inability to aromatize sufficiently. So low estradiol. Too much prolactin or too little prolactin. And then we get into adrenaline. Okay, adrenaline leads to acute hypertension, which will destroy an erection. Allostatic loads, which is a chronic state of adrenal overload, which leads to chronic hypertension, which will destroy erections. Then we get into non-steroid hormones like insulin, hyperinsulin, which leads to insulin resistance, which leads to thicker blood, which leads to erectile dysfunction. So we can go down this rabbit hole into all of the things that lead to erectile dysfunction from a physiological standpoint. Now understand that 75% of erection quality, once the physiological aspect has been addressed, is psychological. So you have the psychogenic side and you have the physiologic side, and both must intertwine in order for a quality erection to occur. So as much as I love the field of hormones and the intricacies that come with it, the sexual medical side is significantly more complex. And I enjoy that a lot as well, but it is not a quick and simple assessment. We usually do 45 minutes to an hour of conversation with an erectile dysfunction patient to really get to the root cause. You have to understand, we don't accept idiopathic diagnoses before we treat. We have to pinpoint a cause. And we don't like the empirical way of treating and just throwing everything at the kitchen sink and hoping that something sticks. We really want to get down to the nitty-gritty of what caused the problem.
Sure. Can you say if HRT would make BPH worse?
Can it make it worse? Yes, when it is mismanaged and not properly explained to a patient, or misunderstood by a patient, or user error on the patient's end. Should it make it worse? No. PSA in and of itself is not indicative of BPH. PSA is extremely transient. If you understand the things that drive PSA, you wouldn't be as concerned and as obsessed with it, especially when you take a snapshot in time, which is essentially what a blood draw lab is. However, BPH in and of itself is something that will occur in every male if we live long enough to experience it. A 90-year-old will always have a larger prostate than a 19-year-old, and there's nothing anyone can do about that. However, people always blame testosterone. Why? Because around the age where men start to experience some levels of BPH, and around the age where men initially start testing PSA, which is, according to the American Urological Association, is at the age of 40 and up, that is usually also when men go on testosterone. So the correlation of the timeline for when people start to look at something, coupled with when they start testosterone, happens to line up. So testosterone always takes the blame. Okay, if I brush dust under my rug for 10 years and I never look under the rug, I don't know that there's dust there. It's presumed, but it is not evidence. If I happen to have my doorbell ring 10 years from now, and as the doorbell rings, I lift up my rug and I see all the dust from all the years, can I now safely say that when the doorbell rings, it causes dust to accumulate? Because they happen to be around the same time. The answer is no. Unfortunately, men start testosterone around the time when they start regular urology visits for their prostate, and that correlation is made. There is no evidence whatsoever, and Morgenthaler out of Harvard has done tons of research and published a lot of literature on this. I attended a seminar earlier this year, specifically on prostate cancer and testosterone therapy, and it was 3 days of him explaining and presenting the evidence of why there isn't any. So again, it's been debunked, but it doesn't matter how many times we beat this dead horse. Just like with estradiol, people will continue to believe what they want to believe. They'll continue to go after the old science of their PCPs, their endos, and the euros, and they'll just keep saying estrogen's bad for you and testosterone causes prostate cancer. And this is the exhausting part of what we do, unfortunately.
What's the best thing to take for energy? I've been on TRT for almost 2 years, and ever since the honeymoon ended, I'm low energy no matter what my dose is. My latest labs was total 1,321 and 335.
Testosterone is not a central nervous system stimulant. It is not a cup of coffee. It is not something you feel. And if you do, it is a placebo effect, which is psychological. Energy comes from good mitochondrial health. Your mitochondria are responsible for converting glucose and oxygen into ATP, which is cellular energy. Start assessing your nutrition, your sleep, your exercise, and your cellular health. Avoid pathogens, increase antioxidants, increase the amount of movement, decrease the amount of processed foods and junk that you consume, and improve the quality of your sleep, which we discussed about 10 minutes ago, and you should see a proper incline or rise in energy levels. And reduce stress. Stress will burn out any level of energy or motivation that you have.
I've been on TRT for 3 years now and have been taking tamoxifen for about 5 years because of gynecomastia reasons. When I stop tamoxifen, the gyno returns slowly. Is it safe to stay on tamoxifen?
No, tamoxifen will drive your SHBG significantly higher, and it also inhibits a lot of the benefits of TRT. SERMs are not good for you. They are designed as either a transient medication for a short period of time for an acute purpose, or for elongated periods for women with breast cancer, where again, they do cause harm, but at the risk of keeping you alive. Men living on tamoxifen or any serum for that matter for extended periods of time are doing themselves a tremendous disservice to their body and their health long term. The only, and he may not want to hear this, but this is factual, the only way to address chronic gynecomastia, which is mostly a genetic predisposition, is via surgery to remove the gland. That is the only way. But to live on tamoxifen for 5 years, absolutely not.
How often should you test SHBG? Should administration be adjusted, either dose or frequency, based on varying SHBG results?
How long should you do what? I'm sorry?
How often should you test SHBG? And should administration be adjusted based on SHBG results?
Yeah, every time you do labs for your HRT provider, they should be checking your SHBG every single time. On average, our patients are tested 3 to 5 times per year, depending on the individual, depending on how long they've been with us. We have guys that are once every 6 months or twice a year if they've been, kind of in an optimal state for a while. But most of our newer guys, 3 to 5 labs per year. SHBG is pulled on every single lab. It is by far the single most important marker once on therapy in order to manage the correct dosing and frequency of your therapy, because it is the driving vehicle of your testosterone.
A very general question. Not bad. What is the difference between injecting once a week, twice a week, every other day, and every day?
The difference is frequency. What do you mean, what is the difference? The frequency is determined by a competent provider who understands how SHBG mitigates delivery and excretion of the hormone. Also, the larger the bolus, the bigger the crushing effect on SHBG. So according to where SHBG is, we determine the frequency. Frequency is not just something you experiment with, it is a science, and it is a little bit of an art.
Yeah, this is a guy, Ibrahim Ali. He really needs a good provider, because the second question there is how to adjust my protocol, how to know when to increase or decrease it. Everyone says change one thing at a time. However, no one goes into detail what thing means.
What this means, one thing at a time means one thing at a time. You have what we call variables. A variable is every element that can be impacted or controlled. Frequency is a variable. Dose is a variable. Ester is a variable. Carrier oil is a variable. All of these variables are variables that when we say change one at a time, one at a time. Don't change dose and frequency. Now, this is not a golden rule to abide by everyone. For example, if I see someone come back with a low SHBG and a very low level of total and or free testosterone, then we may change more than one variable. We may increase their frequency and also increase the dose at the same time, because we know that change is coming anyway. So with the vast amount of experience of doing this, literally probably over 10,000 times now with patients over the years, we can pretty much guess pretty well at this point, based on anecdotal experience, what this individual is going to need. So rather than making one change and then 3 months later making a second change and taking 6 months to reach our destination, we may make 2 changes at once in order to reach that destination sooner, because we kind of already have an idea of how they are going to respond. With that said, if you have, or if your provider has the experience, you as an individual, you'll never have the level of experience of a provider who's done this with thousands of patients. But if your provider has the experience and know-how, then they may change more than one variable at a time. But ideally, if unsure, it is always safer to take baby steps, because here's the thing, you make 2 changes and something goes sideways. Now you don't know why, you have to undo both and you're going back to square one. Whereas if you made one change at a time and it didn't go well, you can pinpoint that that was the root cause, presumably. So that's why we say one at a time. It just makes it easier to dial in.
Yeah, guys, viewers, too much question. Yeah, go. Oh, all right. A lot of questions are coming in. Too much, we won't be able to answer everything, and we also have a lot of questions under the original Facebook posts. So if you want to have your question pop up, give us a, how do you call it, a tip or a super chat, something like that. I'm going to take some questions from under the original Facebook post, Gil. When transitioning from 20% compounded TRT cream to emmentate injections, would you recommend a few weeks overlap with a gradual reduction of the cream to allow time for the injections to build up?
Cream is out of your system in a matter of days. Once discontinued, the half-life is extremely short. Literally, stop your cream. The next day, begin your injection protocol. But again, this should be guided by a competent provider. All of these protocol questions should be directed towards a provider, because here's the thing. I appreciate people wanting to know the information. I'm happy to provide it. For you to take information that you hear here and then bring that to your provider, you have to stop and think, is your job to educate a medical professional on how to manage you? Right? A player doesn't go to this coach and say, here's the play. The coach determines the play. The player goes out and does it. You guys are the players. You're not the coaches. Your coach is being paid to manage you. And if your coach doesn't have a playbook that is destined for winning, then get a new coach. Because taking another coach's playbook and bringing it to your coach is not, I mean, you're not there to teach them how to do it. They won't even understand why. So if they're not taking it upon themselves to stay on top of the latest research and data and actually do this correctly, if they don't do this day in and day out as their primary focus, if they treat everything under the sun and, oh, by the way, I can also handle TRT for you, no, they're way out of their element, right? Your dentist does root canals all day. He's not going to say, hey, I think I can perform open heart surgery. Let me give it a run, right? As silly as that sounds to you, that's how silly going to a primary care physician for TRT sounds to us.
On the previous Q&A, you mentioned taking vitamin A in addition to vitamin D, K2, magnesium, creatine, etc. What role does vitamin A play and how much?
Well, you have a lot more vitamin A experience than I do as a dermatologist. I know you guys use it a lot for acne.
Yeah.
At higher doses. Listen, you know, if you look at the fat soluble vitamins, which is A, D, E, and K, all right, you should have all of those. I know vitamin A, there was a protocol back when COVID was prevalent. People used to say, 10,000 IUs of vitamin A, 10,000 IUs of vitamin D, 3 grams a day of vitamin C. So all of those protocols presumably synergistically helped the immune system. That is a field that is outside the realm of my specialty. It is something that I've personally taken for a while. It is something that I find makes people feel better, and they tend to get sick less often. I believe vitamin A also has a role in vision health, right? Correct me if I'm wrong, Stephen.
Yeah, vision, skin, collagen production, sebum production reduced. That's why we use it for acne, inflammation,
Yeah,
cysts,
so
and
if you
so on.
reduce sebum, you have less clogged pores and less acne risk. So there's no harm. Look, vitamins, for the most part, as long as you don't overdose them, they're not going to harm you. So, err on the side of following the manufacturer's suggestion. And if you're going to go above that, then speak to whoever recommended them to you specifically to find an optimal dose. There is no one-size-fits-all dosing in almost anything in life. Not in food, not in medicine, not in supplements.
Yeah, even for skin, we use a lot of tretinoin cream. It's like isotretinoin, that's the Accutane. You have also the tretinoin in the cream. You can use it locally. It's good for skin, anti-skin aging, and also to reduce sebum production, acne, and so on. So that's very
Anything that
easy to
enhances
combine.
collagen is gonna be a very good for the health of your skin, because it helps to maintain the cushioning underneath.
Yeah, it does. What's your opinion on gonadorelin as opposed to HCG in prevention of testicular atrophy?
So gonadorelin is a medication that is an analog for gonadotropin releasing hormone, or GnRH. What that does is essentially it mimics what the hypothalamus releases prior to getting to the pituitary and telling it to release luteinizing hormone. If your pituitary has good function, then it may, and I say may because not always, but it may work. The problem is that because the anterior pituitary, which sits in the front of your brain, is responsible for luteinizing hormone, and anyone who's had any level of TBI, which is traumatic brain injury, or any sort of head trauma like a concussion, and a lot of guys have, whether it be football, MMA, car accident, military, whatever the case is, if you've ever suffered a concussion, then presumably there's going to be some level of damage to the anterior pituitary, and it may throw off the gonadotropin signaling. So luteinizing hormone levels, and this can also be impacted by drugs, alcohol, over-the-counter medication, and poor sleep, as well as stress levels. All of these factors, which now we're starting to encompass the masses as far as the population goes, right? Now, the more of these things we name, the more people are probably saying, hey, that sounds like me. Your luteinizing level hormones are going to be low. So stimulating a pituitary that is lagging or already fatigued is like kicking a dead horse. It's not going to do a whole lot. So releasing more GnRH, which is gonadotropin, what it does is, gonadorelin, is it mimics GnRH. It simply tells the pituitary to work harder. But telling a failed gland to work harder is not really going to do a whole lot. What HCG does is it mimics luteinizing hormone. It bypasses the pituitary's need to actually produce any gonadotropins, and it actually provides your testicles directly with a gonadotropic signal called luteinizing hormone. So it is significantly more effective because think of getting closer to the scene of the accident, right? We can't like clear the roadway from, 2 miles back. We got to be like right on top of the problem. And for most men, the problem is the pituitary, not the hypothalamus.
Our friend Bruno da Silva, who asked about the chronic intake of tamoxifen, he asked, is there any replacement for tamoxifen? He already had a surgery done, but with TRT, no matter what, does the symptoms come back a little? What else can I use to replace it?
Yeah, so we see this often, unfortunately, and I'll give you the sad news. If you've had gyno surgery done and you're still getting gynecomastia, they fail to remove the full gland, unfortunately. And we see this often. They removed partial. They need to remove the full gland. And unfortunately, the answer for you long-term is to go back and have the surgery done correctly.
Yeah.
Because if they remove the full gland, there's nothing there to inflame. So you should not have gynecomastia. You should also check your prolactin levels, because prolactin, right, as the name suggests, is prolactin, prolactation. It is a lactating hormone, which causes the breast tissue to engorge, which is what allows women post-pregnancy to breastfeed. So if you have elevated prolactin, you're going to inflame the mammary gland.
Yeah, I have questions everywhere. And the pop-up books. Facebook. Questions everywhere. I'd like them to discuss sleep anxiety. How do they define that? Is it waking in the middle of the night, unable to sleep, or going back to sleep? Or are there any other factors, symptoms?
Yeah, going back to the first topic we discussed today. So, if you have anxiety all night long, you probably have anxiety during the day. You probably have a very stressful life. You really should assess the stressors. Go ahead and grab a piece of paper and write down the top 3 things in your life that if I handed you a magic wand right now and I said you can eliminate these aspects, what would they be? And write those down and then work on deriving a plan, working backwards. What is the first thing that needs to happen or the last thing that needs to happen before this item is gone? And build a plan down to where you are today and follow that blueprint to get rid of that stressor. Once you eliminate the top stressors in your life, your anxiety should reduce and then you should be able to have better sleep. You're going to bed with a lot of worries on your mind and it is keeping you up. Okay, so guess what? It's a snowball effect. The worse you sleep, the worse your next day is going to be, the more anxious you're going to be, and the more irritable you're going to be. That leads to emotional decisions, which always lead to mistakes, and mistakes lead to more stress. So this snowballing effect needs to be nipped by stopping, identifying, and correcting. It's very similar to the medical model. We do an assessment by getting the subjective data from the patient, by looking at the objective aspects that are presented to us, putting them together and deriving a blueprint on how we fix the problem by diagnosing the problem. If you don't diagnose the root cause of your stresses, you will never be able to truly eliminate or fix them. And you have to understand, I can't stress it enough, the longer it lingers, the worse it gets, because you're going to continue to make mistakes and lead a life of irritability. It's only going to get worse. This is evidenced by guys in their 40s and 50s. They look extremely run down, overweight, just completely fallen apart. They look 10, 15 years older than they are. And that is because they have gone through chronic stress that has never been addressed. And, they're up at 3 a.m. They're up at 3. You look at their social media posts, they're always 2, 3 a.m, right?
Yeah. Any tips for
delayed
orgasm?
Get rid of alcohol. I'm sorry. Have to stress, get rid of alcohol. Yeah. And if you live on caffeine, listen, I love coffee. I have 1 a.m. That's it for the day. I know guys drink 5, 6 cups of coffee a day. You'll never sleep. You will never sleep. Get rid of stimulants. All right. Get rid of amphetamines like Adderall. Get rid of caffeine. Get rid of alcohol. Get rid of the things that are causing you to be up at night.
Any tips for delayed orgasm on TRT?
Yeah, we find this often after long periods of time. Sometimes it's desensitization. And 2 things that I have found anecdotally that help is, for some men, HCG does tend to help. For other men, DHEA, 25 milligrams in the morning, has been shown to possibly help. And then lastly, if your SHBG is too low, you're going to have delayed orgasm or anorgasmia, which is an inability to achieve orgasm indefinitely. So SHBG, again, management, I can't stress how crucial this is. SHBG management is very important, and it needs to be done by someone who is competent. Now, if you don't mind, Stephen, people always ask at the end. I know not everyone stays on till the end. I'd like to give people an opportunity, if they'd like, to reach out to my office. We do treat in the United States, no matter where you are, via virtual appointments. We can call you on the phone. We can send you a requisition to go to your local lab, get blood done. We'll receive the results and book you for a phone call. We can actually also have prescriptions from a licensed pharmacy shipped directly to your home, and we can manage you on an ongoing basis. If you live in the United States, go to elevatewellnessgroup.com. You click on the telemed where it says, where you are. So it's not, you don't pick one of my physical locations per se, but you click telemed, you just put in your contact information. My office calls you within 1 business day, and we can get you set up. So you could be treated by myself and my staff if you'd like, because people always do ask. So I just want to put it out there because I know not everyone stays the full length. So again, elevatewellnessgroup.com.
Do you think it will ever be possible to fool the endocrine system into maintaining your endogenous T production while adding an amount of exogenous testosterone?
So no, and you shouldn't really strive for that, because you have to understand how a negative loop works, which is what our endocrine system is designed to do. Specifically, the hypothalamic pituitary testicular axis. It's a negative feedback, which means that when one signal goes up, it drives another signal, and then when that signal goes up, the initial signaling agent drops. So when luteinizing hormone levels go up and you produce more testosterone, that testosterone production causes that LH level to drop. When you introduce exogenous levels of testosterone that are sufficient for your body, your luteinizing hormone levels will be suppressed. They will drop. So the short answer is no. The longer answer is we can mimic luteinizing hormone with luteinizing hormone analogs, such as HCG. So a little bit of HCG drizzled, usually about twice a week on a low dose, can maintain testicular function. We use it in patients who want to prevent testicular atrophy, and only about 25% of patients actually do experience it, so it's not a one-size-fits-all. And we use it in patients who may want to conceive a child in the future, again, to maintain the latex cell activity within their testicles. So in the future, when they are ready to conceive, we can add in a medication called FSH, or follicle stimulating hormone, which helps the production of sperm, also called spermatogenesis. So all of this could be done if we want to preserve some level of testicular function. But when it comes to actual hormone regulation, it's not needed. Your exogenous testosterone, when managed correctly, is more than sufficient to give you everything you'll need.
Yeah. Next question is from a young guy, 21 years old. He really might need some help there. He has a 9 SHBG, but it's not genetic. How can I raise it? Total 11 nanomoles. I feel like shit, no providers in my country.
The first thing I would test for a guy with SHBG in the single digits is his fasting insulin and hemoglobin A1C. Because the biggest cause of low SHBG we find is insulin resistance. Insulin antagonizes SHBG production. And when you have chronic levels of insulin in the blood, secondary to elevated blood sugar, you can expect SHBG to come down. So SHBG is not only essential in regulating hormone management, it is also a great precursor to help potentially diagnose metabolic syndromes. So if you have obesity and or insulin resistance, oftentimes we expect to see a low SHBG. And if you have a low SHBG, oftentimes we expect to see insulin resistance. So if it's never been tested, I would test it. He is young, but nowadays we're finding insulin resistant in teenagers as well. So that's the first place I would look. It is inexpensive to do so. It is a spot test and it is extremely easy to do. Beyond that, I would look at the liver health. I would look at other medications. I would look at potential hepatotoxic over-the-counter drugs like Tylenol. I would look at alcohol use. I would look at sleep, and I would look at diet. So if you're eating a lot of sugar, a lot of carbohydrates, not a lot of protein and fiber, then again, I would expect SHBG to be low, because even though you may not be insulin resistant, you are spiking your sugar quite often, and you still have hyperinsulin in your blood. And these are all lifestyle factors that could be mitigated.
Mm-hmm.
And lastly, we would assess symptoms. I mean, sometimes that is just your number genetically, and there's nothing wrong with it if you're not symptomatic.
Mm-hmm. Is there a place? Is there a place for a DHT cream in an HRT protocol?
DHT cream?
Cream, yeah.
DHT is a metabolite, much like estradiol. It is self-regulated, and barring any intervention, it really should be managed by the body. So as long as you're providing your body with optimal levels of testosterone, dihydrotestosterone, which comes from the 5-alpha reductase enzyme, which is actually an anabolic process. It is essentially a testosterone molecule with 2 more hydrogens added. So you have 19 carbons, and then you have 30 hydrogens and 2 oxygens if you break down the molecular structure of DHT. As long as you are drinking a lot of water, not interfering with your 5-alpha reductase, not taking 5-AR inhibitors like finasteride, for example, then you don't need any exogenous DHT, just like you wouldn't need any exogenous estradiol per se.
Mm. Yeah, more and more clinics are selling DHT.
It's money, my friend. We know this. Clinics will sell you anything they can make a buck on. All right. My goal in my office, our guys pay for management, knowledge, and access. Okay. We don't earn extra money by putting you on all these ancillary pills and stuff. You know, if guys want performance-based medications that are non-controlled, like peptides or vitamins and stuff like that, that's fine. If guys want to start getting on hormones that they don't need, we're not going to provide that to enrich in our pockets. That is not proper medicine. We're not a retail store. We're a medical office, and our goal is to treat medical necessities, not sell you everything on the shelf. That I just hate to see it. It's a black eye for the industry, unfortunately. And this is the problem with a lot of these, offices now being owned by business people rather than medical people. They just want to see the bottom line numbers, and they're pushing their providers to prescribe everything available. I see 21-year-olds getting all types of steroids because they're willing to pay $3,000 a month for them. It's sickening to see.
Male pattern baldness is an increased risk going on TRT, but what about alopecia areata if you have had that in the past?
Any genetic predisposition to hair loss, it's not that TRT increases the risk. It's that you already have the gene. It's going to happen. An increased level of DHT may only accelerate a little bit. So let's say you're going to lose your hair at 50. You may lose it now at like 46 because you're on a higher level of DHT. To me, that trade-off is well worth it. I mean, why should you suffer those 5 years and then you're going to lose it anyway? I mean, look at Steven. Handsome as a devil, and I don't know the last time he had any hair on his head, right? But at the end of the day, look at his physique and look at the way he feels and look at the way, I think we're the same age. I'm 47.
50.
Oh, 50. Look at this guy, 50 years old, has been living optimally for God knows how many years. Would you have lived the last 10 years or whatever without testosterone just to get a little more hair? No. Absolutely not. I don't know any man who's optimal on his hormones that would say, I would have suffered with low T for the last decade just so I could have had a wig on my head. Give me a break. I'll shave my head tomorrow if you told me I have to lose my testosterone.
Yeah. I talked about that yesterday. It's still a video that has to be published with Dave and Kyle Chiret. We talked about blocking DHT, and there Dave tells us a story about his hair loss because he was very fancy of his long hair. And I will show you some pictures in that video, something to look out for.
Finasteride is the devil. It'll destroy your life. It'll destroy your life.
Yeah.
But hey, they'll sell it to you for money.
Exactly. Any methods or supplements to raise super low SHBG besides low carb diet? How to typically raise patients' SHBG when it crashed low?
If you're otherwise healthy and you're not insulin resistant or obese, then a low carb diet for 6 to 8 weeks will raise SHBG. From a medical standpoint, SERMs like tamoxifen will also raise SHBG. As much as I'd hate to use it in chronic cases where SHBG is just stubbornly low and very important, not or, but the patient is symptomatic for what we perceive to be low SHBG, like sexual dysfunctions or inability to process testosterone and hang on to testosterone, or they need daily injections and it's becoming tedious, we may trial a 4-week run of tamoxifen at 20 milligrams a day, and that usually will get their SHBG up into the 20s.
What is a good number for SHBG for a 64-year-old male?
It's not about your age, because a good number doesn't change because of your age. A good number is a good number. What your age does is it pulls you out of that good range. So as we age, SHBG tends to come up. As the liver starts to get tired, SHBG tends to come up. So guys in their mid-60s, usually we're going to find SHBGs like in the 70s, 80s, 90s, and that's terrible because they have no free T. We love to see SHBG like around 30, 35. Like that is a nice sweet spot where you still have sufficient levels of binding protein to carry some testosterone, where you can be on a twice-a-week protocol, but you still have some level of free testosterone at about 2.5% of total. That is a nice range to shoot for. And we find most symptom resolution occurs in that range. But it's very rare to have somebody who is not diabetic, right, and artificially low, to have SHBG, below like 50. If they are, in their 60s. It's just very rare to see. That's why, again, I think every man in that age group should be on TRT. Heck, you probably should have been on TRT 2 decades ago. I'm 47. I've been on TRT for 10 years now.
Awesome. Last question. Can HGH, not HCG, help at all when coming off TRT? Like help kickstart the testicles again?
Unrelated completely. No, it's got nothing to do with any of it. Nothing. It's like saying, can vacuuming my living room help me when I'm hungry? Okay. It's literally how it sounds to us. Like it's got nothing to do with it. Nothing. Zero. Absolutely zero. It's not even the same pathway, not the same mechanism. Nothing to do with it.
All right. Okay.
Again, a clinic who recommended it because they want to make $1,000 on a vial of HGH. I mean, that's really what that's where these questions come from. Yeah. It's from a provider saying, hey, you have low testosterone, but if you want to get on testosterone, we'll put you on growth hormone. Idiocy. Complete idiocy. Yeah.
Okay, Gil, also almost 1 hour. So thank you so much for taking your time to do this Q&A.
It's a pleasure. Thank you as always. And once again, if anyone has an interest in reaching out to me or my offices, we can treat nationwide across the United States. Simply go to elevatewellnessgroup.com, input your name, phone number, and email. We will reach out to you within 24 business hours, and we can treat you virtually. You don't have to come here. We can treat you virtually anywhere in the United States.
And the link will be in the description of every video you see Gil in.
Appreciate it. Thank you, Stephen.
Okay, thank you so much, Gil. Talk to you next time and enjoy the rest of your weekend.
You as well. Thank you.
Bye, mate.
Bye-bye.